Good afternoon. On behalf of the Centers for Medicare and Medicaid Services, the Administration for Living, and the Indian Health Service, I would like to welcome you to today's long-term services and support webinar series. My name is Brittany Smiley with Kaufman and Associates, and I'll be your moderator today. Before we begin, I would like to highlight some main features of the Zoom interface. So if you lose connectivity during the session, please click the join link to re-access the webinar. If you experience technical difficulties, please send us a note using the chat box feature in the bottom of the menu bar, and we will assist you from there. Another menu option is your raised hand icon. Please use that feature when you would like for us to unmute you and answer a question during the Q&A segment. Additionally, live captioning is available during today's broadcast. Simply click on the CC icon from your bottom menu bar to use this feature. Please be aware that today's webinar is being recorded and that the recording will be made available online in the near future on cms.gov. If you would like a copy of the slides sent to you directly, I will place the email address in the chat feature for you to send the email. The disclaimer. The webinar series is supported by GF008F0012S, awarded by the Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenters and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicaid Services. At this time, I would like to introduce our panelists today. We have Larry Curley, Cindy Curley, Rebecca Al Morgan, and Mike Tuggan. And at this time, I'd like to turn it over to Becky.
Hello and welcome. I'm Becky Al Morgan. I'm project coordinator at NICOA, and I'm a member of the Eastern Band of Cherokee Indians. Thank you very much for joining us today. Our goal is to provide an overview of our Tribal Long-Term Services and Supports National Resource Center. Informally, we call it the NICOA Compass LTSS, since our aim is to provide people with a sense of direction about where they're going regarding tribal LTSS. NICOA is over 40 years old and was started by tribal leaders such as Wendell Chino. The project is a cooperative agreement, and I'll summarize some of the work that we've been undertaking. The first deliverable is to create a website, which we've done, and we've also created an information and data clearinghouse that's on the LTSS website. We are in the process of hiring navigators to provide training and technical assistance to tribes via Zoom and other virtual methods during tribal shutdowns due to COVID and other public health emergencies. We provided education and outreach materials to tribal community members, federal agencies, and stakeholders. And we've been meeting with our advisory committee on a quarterly basis to help guide the work of the tribal LTSS NRC. We've been advancing and developing partnerships to expand our reach, and we've created a database of potential funders to help us sustain the work of the LTSS Compass. So that's the deliverables and the aims of the project. The other idea that we wanted to do is to provide a continuum of care. And I think that Larry and Mike and Cindy will talk about that more. Next, I would like to turn it over to Mike Tungate, who will do a live demo of our website. Mike.
Hey everybody, my name is Mike Tungate and I'm the Web Services Manager at Envision Solutions, and we have been helping NICOA with web needs. We've developed several websites for NICOA, and this is one of the projects that we've helped them to develop. Let me go ahead and share my screen real quick. So this is the homepage of the NICOA LTSS Compass website. Now, as somebody who designs websites regularly, one of the things that I always tell clients and prospective clients is you always have to look at the website from a person's perspective who doesn't know anything about what you're trying to explain to them or deliver to them. You can't take anything for granted for the most part. So one of the things that we kind of thought about and talked about when we were originally talking about developing the website is, not everybody's going to know what LTSS is or what it means or what it does. I mean, there's going to be people who come here who are going to be experts on LTSS, but some people aren't going to have any idea what it is. And so that's one of the things that we wanted to do right off the bat is talk about, what is LTSS? And, from our definition, one of the things about LTSS is that LTSS is really just about wellness, overall wellness. Let me just run through some of the stuff on the homepage here real quick. Then we have a disclaimer on the website about the grant information and that kind of thing. But then we go down to a little bit more of a in depth about what LTSS is, and you can always click this button to learn more about that. And one of the things once again, when we first met about this website, Larry Curley, executive director of NICOA, was very adamant about no rabbit holes. It's what we used to tell each other, what we still tell each other about the website. Keep it simple. So that's kind of the thing we ran with the website as a whole. And one of the things we wanted to do was kind of create more of a graphic heavy website versus text heavy website. Although because this is an informational website, there's a lot of text as well. But especially on the homepage, kind of your intro into the website, we wanted to create kind of interactive graphics. So this is essentially what we call the LTSS compass, if you will. And it is an interactive compass that lets you go to the kind of the four main parts of the website. You could learn about what is LTSS. You can learn about the services that are available in your area, paying for your care for the community, and for tribal leaders. And that's really kind of all the home pages as it has on it. You'll see a lot of home pages on websites that are just very complex and sometimes overwhelming. We really didn't want that. So if we look at one of the main things that we had met about and talked about, and talked about different ways to do it, we looked at all the existing mapping systems out there, and so we decided to kind of do things a little differently. And so this is a custom map of the U.S. That we keep adding to, and what essentially all the dark green areas are areas that are really areas that we're heavily working on. We're almost completely done with these 3 areas, by the way. We're going to moving into a couple areas up north here, but the light green are areas we haven't touched yet for the most part. So if you go into your own particular state, let's say it's New Mexico, that's where we are, you can search by tribe or you can search by county. So if you go into the tribal search area, it doesn't really go into the mapping system that we've created. Essentially what it does is it goes into the Native Elder Service Locator, and it gives you some information that way. What we have set up on the actual mapping system on the website is it's based on your county. We assume everybody kind of knows their general county, and so I'm just going to click on a random county here, and essentially there are services in your county that we want to help you to find quickly. And so if you're in Lea County, for instance, and you're looking at maybe senior centers, so you click and you go into a page about senior centers, and every one of the things I mentioned in the very beginning is we don't take anything for granted. We don't assume that what a senior center is, and so we kind of every service has a section at the top that kind of roughly explains what that is, and you can always find out more information by clicking on the learn more link or text reference from here area. But anyway, here's the mapping system itself, and one of the cool things about this is it's an interactive real-time Google map. And so you can zoom, you can click on links, you can get addresses and phone numbers and that kind of thing. And these are senior centers in the Lea County area, New Mexico. So we think it's going to be helpful to people. And one of the things that we wanted to do as well is we wanted this to be very interactive and very group oriented and community based. So we wanted people to be able to reach out if they have any questions, if there's an error, if they're like, yeah, you guys are missing so-and-so service, or this is the wrong map or whatever. We want people to be able to quickly reach out. I did want to mention something real quick I forgot about, is the colors on the website that we used are really for the most part based on the medicine wheel colors. So yeah, you have your yellow, red, and your black, and we kind of used a fourth color of gray, and that's kind of the same color system we have here. If you click on Find LTSS Services, you'll notice that the banner is black for the community. The banner is yellow. It's harder to tell here for tribal leaders, but it's white, and then you have gray. So we try to lead people down a path visually as well. One of the things that I wanted to point out that we put on the website, which came from CMS, we just kind of borrow their content and put links back to it if people want to keep researching there. But we put an interactive compass on this page as well. So if you're looking at evaluation or whatever, you can come down to that. You can keep scrolling, and that same navigation's right here that follows you along. There's also kind of a neat little tool. It's like a progress bar at the very top that kind of follows you down the page, so you can kind of get an idea of how long the page is. It's a pretty long page. That's why we've really tried to put in some navigation here to help you to navigate through this. This is something that we've tried to do a lot too, and we will, as we keep going, is put more video in the website, because we think video is very helpful to understand things. Some people prefer video to text-heavy pages like this. And let me pop over to some of. I wanted to mention something about these pages in general as well. We opted to not have any drop downs on the website. If you've noticed, as you hover above this, and there's no drop downs at all. So what happens is essentially you click on the button, and these are essentially what your drop downs would be anyway. But we find this to be a little more user friendly than drop downs. Drop downs can be cumbersome. They can be tricky. So we thought a lot about this, and we wanted to eliminate drop downs and put in this system. And you can click to each of these links. There's kind of a visual cue of what these links are. Let me actually talk about the nutrition real quick, because we're pretty proud of this page. So in some of the meetings have had in the past, Larry Curley has talked a lot about really like cultural preservation and that kind of stuff. And this is one way, we've decided that's really important, is to try to keep the some of the Native American recipes in the public view, and maybe people can try these recipes out, and they can share these recipes and that kind of stuff. So we talk about nutrition as a whole, but then you can go in here, you can go into the recipe section, and this is an ever expanding thing. We're going to keep going on this, but we talk about just overall just nutrition stuff, and then we have videos over here where people can learn about different stuff through video, like I said before, because some people do prefer that. And so that's generally all I wanted to show you on the website. I don't have a lot of time, so I'm kind of moving quickly, and I apologize for that. But I do want to touch on some of the analytics for the website. I put the data out to April till now. And just to show some of the feedback from the website and some of the user interaction. I'm just going to talk once again, pretty quickly about this stuff. I tend to talk pretty quickly anyway, but I'm talking quicker now because I want to get through this stuff. Just some highlight points. The bounce rate is essentially when somebody goes to the website, instantly leaves. A bounce rate of 50% is actually very good for the website, so we're pretty happy about that. And so, generally speaking, that's a very good bounce rate. Let me talk real quick just about some of the referrals on the website. So referral traffic is essentially traffic that refers to your website. People click links on other websites to get to your website. As you can tell, mobile Facebook, that's what m.facebook is a very huge refer to the NICOA LTSS Compass website, and then NICOA. What's interesting about this is we looked at this data recently, and it was flipped. It was NICOA and Facebook. So NICOA internally has probably been doing a lot of Facebook posting about NICOA, and then people have been, about the Compass website, and they've been going there, which is great. Let me just do a couple more things. We thought this was pretty interesting. This is something you never know about a website, what the user demographics are. And then we were pretty surprised to find out that the 25 to 34 age group is the most popular visitor on the website, and it's female as well. We thought that was pretty interesting. Let me look at, just touch on this real quick and talk about where traffic is coming from statewide. It's New Mexico and Washington, California, and then Oregon, Texas, are kind of the top 5 visitors. We were pretty surprised about California, actually. We talked about potentially maybe doing mapping for California since a lot of people are visiting from California. New and returning visitors. This is important because on a website that we want is very heavy informational, kind of a reference website. We want a lot more returning visitors than 10%, but I think that'll happen as the website ages and more people start coming to the website. Desktop versus mobile. This is pretty important too, so you can see how people are surfing the website to see if maybe your mobile site needs more work than your desktop site and that kind of thing. And one more slide and then I'm done. This kind of just shows the user flow of the website. I don't think I've shown this before, but the / is your homepage. And then you can kind of see where people go from there. A lot of people go to, in fact, most people at this point are going to find LTSS services, which is interesting. And then they just, go from there. I know I'm moving quickly on this stuff and I apologize for doing that, but I just wanted to get through it before my time was over. Let me know if anybody has any questions in the chat and I can chat with them. I apologize for, like I said, talking so fast, but thank you.
And now we'll move to Larry Curley.
Hello, I'm glad all of you are sitting in, listening in on this. One of the things about the LTSS site, as Becky mentioned, is that it's not just a website. We have a lot of other activities that are tied to this particular cooperative agreement. So the focus right now is the website itself. When we started talking about the LTSS system, what is it that LTSS is? Long-term services and support in Indian country. There's always that question about, well, if we wanted to start something like that, what do we do? How would we start? Well, one of the things, next slide, is that you might want to take a look at how your service providers are in the tribe and in the community. And the one on the right-hand side shows like social services, elders, health clinic, Head Start, courts. Is that what it looks like? And if that's what it looks like, then you have a fragmented system. It's mostly, we talk about it being silos. But I also want to just say at the very beginning that the whole LTSS system, I have my first brush with LTSS way back in 1974 when I was a gerontological planner for an area agency on aging in Tucson, Arizona. And they had a project that was funded by HUD called Model Cities Project. And they had an integrated system. And where the question about, is there coordination? Is there collaboration between the different providers in the community? So what I'm presenting here, what we're presenting here is based on my experience and my knowledge of 44 years in the field of aging. Next slide, please. Now, if this is, next slide. Now, if what you've seen of the silos, if you're interested in making sure that all of these different departments in your tribe, if you want them to work together, this is how it would look like, where the elders become the focus of all of these service providers, social service, the health clinic, the Head Start, the high school. And what is some of the things that are beneficial as a result of it? Well, it identifies what some of the benefits are. Next slide, please. And if that's what you want, well, how do you begin? You might want to start by bringing some people together, some of the program people, some community members, and find out what they think about the idea. And this whole process, bring all of these individuals together, sit around the table and begin talking about, what do you think about this? Do you think it's something you would like? Next slide, please. And tribes have been doing this. They've been providing LTSS, but they're fragmented. There are different departments. And so the difference here is that you're bringing all of these people together to try to address what we call the continuum of care. People who are well, people who might need support, people who need long-term care services, a long-term care facility, a nursing home, institutionalized. The goal of what we're trying to do is to make sure that our elders stay in their own homes as long as possible. That's what this particular project and what we're trying to do overall. Next slide, please. And once you bring all of these people together, you can find out how they feel about doing an LTSS project and putting it all together in your community. Next slide. One of the things that happens is that once you decide that you're going to do it, there are certain things that needs to happen, such as in the human resources department of the tribe, the finance department of the tribe. And as you begin to talk about, is this what you want to do? Then you're talking about, you might need to revise some job descriptions. And over on the finance department side, you might have to think about salaries, those types of things, because you're starting to talk about collaborating and whether the people that you're thinking about hiring and putting in these positions, do they have the specialized training? It might mean that you might have to raise the salaries of some of these individuals as well. Next slide, please. And one of the things that after you've gone through to find out if the community is ready and everybody says, let's go for it. There are two areas, the political side and you have the program side. Most tribes operate by resolution. So you might need to put together a resolution to the tribe, have the tribal council approve it to establish this. The other part of it is the program side, developing MOUs between programs so that they both all understand what the relationships will be. Next slide, please. And one of the things that becomes very important is how are we going to be able to pay for this? Well, one of the biggest provider funding source for an LTSS is the Medicaid program. And there are two ways one can do that. One, you might want to find out who is already affiliated with the Medicaid program. And most tribes, it's usually the health clinic that already has a provider number, has a billing relationship with the Medicaid program in the state. So the health clinic is one. One can affiliate with them, have them work on behalf of the system to do the billing. Or some tribes might say, you know, I would rather just have our elderly program do all of that. Then you have to go through another process, contact the Medicaid program, find out what needs to be done to get a provider number and so forth. So those are two possible ways. Next slide, please. And once you got in the billing organization decided upon, need to get back together, find out who's going to be the case management organization so that they can make sure that our elders don't fall through the cracks. And this is called case management. Find out who are the most elderly person who are most at risk and begin to figure out how each of these departments can provide services to make sure that they provide services that will enable the elderly person to stay in their home as long as possible. Next slide. And remember, you know, what we just gave you is just a very brief overview of looking at an LTSS system. Some of the things that we need to understand is it's not going to be perfect the first time. It doesn't work that way. There will be mistakes made, but I've always looked at mistakes as a learning opportunity. It's like the first time I made fry bread. The first time I made fry bread, you could have rolled that thing and put it onto a truck and drive it and use it as a spare tire. But you keep learning, and that's one of the things. Now, what might be good for let's say the Suquamish tribe might not be something that the Oto Missouri tribe might try, because they're both different tribes, different culture, different history, and so forth. So that basically is the overview on looking at an LTSS system, how you might want to think about approaching that whole process. Next slide, please. As I indicated earlier, we're looking at people on this continuum of care, the well elderly. How do we keep them well? Those people who are needing supportive service, how do we make sure that they have all the services that they need? And then the last part of it is those who are going to require institutionalization. And I know that there are tribes out there who are thinking about building a long-term care facility in their reservation. Oh, just for your information, I'm also a licensed nursing home administrator here in New Mexico. So I know some of these things about the nursing home business. And what are some of the things you might want to consider as a tribe? Next slide, please. And so you might want to take a look at this and say, this is not a comprehensive information. It's more as a generalized overview about some of the process that are involved in this. And as I indicated earlier as well, under the LTSS site, is that a nursing home gets a lot of its funding from the Medicaid program. One of the things that's interesting and noted, should be noted, is that there are 50 states, and each of those 50 states have their own Medicaid program. Each one of them are going to be different. So remember that what we're saying is just remember that as you start thinking about an LT, a long-term care facility. Next slide, please. One of the things that some states requires a certificate of need. Some tribes or some states do not require a certificate of need. And that basically is just to find out whether there is a need for a nursing home in that particular area. Next slide, please. And one of the things very important, where's the money going to be coming from? Medicaid, Medicare, private pay, Veterans Administration, charity. One of the things that we look at, how many individuals are there? What's the payment mixture going to look like? Next slide, please. And take a look at your state Medicaid requirements. Find out what the state Medicaid program requires. What are the qualifications for staff, the building, the water pressure, footage, all of that stuff. Remember, Medicaid programs are different. They have different requirements. So check the Medicaid program in your state. Next slide, please. And as you consider about where do we put this facility? Well, you might want to think about looking at, are we close to specialists? Are we close to hospitals? How about stores and transportation and other conveniences? Next slide, please. And is there sufficient need for the services, the market, the beds, the competition in your area? Those are considerations as you begin to move forward. How many beds do you need? That type of thing. Next slide, please. And as you begin to think about doing this, what are you thinking about in terms of operating expenses, the revenue that's going to be coming into the facility, the Medicaid program, for example, how many are eligible for Medicaid? You need to do an assessment. So these are considerations as you start thinking about a facility. Next slide, please. And part of this is the payment mechanism, the private pay, Veterans Administration, Medicaid, and what are the occupancy ramp up? Is it going to be mostly Medicare, Medicaid, private pay? Those are things that make sure that provides you a consideration of a financial stability. Next slide, please. And remember, once this facility is up, you need to have sufficient funds for it to continue and operate for several months. It's critical. Why? Because state surveyors want to come in and look at the facility. Are you doing the right things? Are your staffing schedules, your medication administration? They're going to take a look at that, but they need to have a record of what you've been doing for the few months that they are going to, before they come in. And CMS will want to know what the specific treatment regimens are for those qualified individuals. And most of all, these operating costs will go unpaid until Medicaid and Medicare participation is approved. So remember that. And that's one of the things that we're trying to say. This is considerations. Next slide, please. And when you're looking at the economy of scale, what are the number of beds? What are the types of beds? Skilled nursing, level 1 behavioral dementia, and the payer mix. Those are the important considerations as you begin to project the economy of scale, payer type services. Next slide, please. And once you've done that, you know where the funds are going to be coming from. Take a look at the governmental programs. You have grants, foundations, fundraising events, and others. Next slide, please. And need to identify how these funds will be used. Land costs, architecture, engineering, furniture, subsidizing patient care during the operation. Those are things that needs to be very clear in the group's mind as you begin considering a long-term care facility. Next slide, please. And who are the people that can help work with you as you go through there? And as you begin planning for this, sharing resources, especially your personnel, referrals, to communication, marketing, all of that. Next slide, please. And what I wanted to do is just let you know that these are things to consider. It's not supposed to be comprehensive. It is a basic approach beginning on how one needs to begin to think about a long-term care facility. And I want to say thank you to a colleague of mine by the name of David Wilgen, who he and I conversed about this, gave me some tips and gave me some information about some of the things to consider. He has been in the nursing home business just as long as I have. And he and I were college classmates at the University of Arizona when we were studying long-term care administration back in the old days. And with that, thank you. And next speaker, Rebecca.
Thank you, Larry. And now we'll move to Cindy Curley.
Hi, my name is Cindy Curley, and I'm working with NICOA, sharing my knowledge as it applies to the LTSS Compass website. Next slide. LTSS in motion. Definition of LTSS. LTSS is a coordinated, collaborative approach to providing care to elders in your community. It may involve senior centers, police departments, social services, courts, behavioral health, schools, clinics, and wellness centers, just to name a few. Elders are living longer, but with long life can come more chronic illness and disability. Native Americans experience high rates of diabetes, cancer, heart disease, and other conditions. Community-based programs help older adults and people with disabilities live at home or in the local settings. The result, better health, more independence, and dignity. Next slide. Combining the public health function and medical model, and here are a couple of examples. The first one is the Public Health Service. They are prevention focused. They work on education and information, screening, control, management. They're population, community, and group based, and they're relatively low cost per capita. The clinical care or medical service model is a need to cure focus. Their diagnosis, treatment, and rehabilitation. Individual patient-based treatment plan, and they are very costly. Combining public health functions and medical models, I did this as a health director, and it worked. It was really successful. I brought in the program directors from other programs such as social services, the police department, senior center, the CHRs, mental health and behavioral health. And we came together as a group, and the focus was to provide comprehensive care and interventions to the same group of people that we shared in common. And it was very successful. Next slide. Some examples of billable LTSS functions in your community is, one is transportation. So senior centers offer home delivered meals, and the CHRs deliver medications. They transport patients to medical appointments, and they conduct wellness checks. They're a good eyes and ears in the community. Some examples of LTSS services in your community are on the community-based side is case management, personal care, caregiver and client training, health promotion and disease prevention, home health activities of daily living and housekeeping, durable medical equipment, and hospice care. On the human services side, you have supporting daily living, senior centers, adult daycare, assistance with bill paying and financial management, home repairs and modifications, which is really crucial when you're dealing with elders with handicaps and disabilities. You want to make sure that they can safely get in and out of their homes. There's no electrical issues, torn carpets, anything that they can trip and fall on. They have safety equipment in their bathroom so they can safely get in and out of the tub. It also provides legal services, respite care, short-term care for primary caregivers. Next slide. Other billable LTSS services, one is case management. Case management is a collaborative process of assessment, planning, facilitation, care coordination, evaluation, and advocacy for options and services to meet an individual and family's comprehensive health needs through communication and available resources to promote patient safety, quality of care, and cost-effective outcomes. Case management consists of services which help beneficiaries gain access and needed medical, behavioral health, social, education, and other services. Billable units for time spent delivering a case management service. The service can be face-to-face, it can be via phone contacts, email, or mail contacts. Next slide. Medicaid differs from state to state. You have to remember it is a state-run program. Examples of Medicaid LTSS programs, New Mexico is one example. Home delivered meals, chore services, and transportation are just a few things that they deliver. Oklahoma, they have home health aides and home-based hospice and therapies, just to name a few. While guided by federal law and regulations, Medicaid is administered by states, which have substantial authority to vary coverage of services, eligibility requirements, and provider reimbursement. Medicaid covers a wide range of LTSS, but coverage varies across states. All states are required to provide coverage for nursing facility services and home health services. States may also offer optional services, including services covered under the Medicaid home and community-based waivers. Next slide. Funding sources for LTSS. Long-term services and supports are financed and private and public dollars, with the majority covered by publicly financed health insurance programs. Medicaid is the primary payer for institutional and community-based LTSS services. Covered services and qualification requirements, they vary by state. Medicare coverage of LTSS for seniors, non-elderly people with disabilities, and people with certain conditions is limited. Medicare provides up to 100 days of long-term care in a skilled nursing facility, hospice care, or some home health care settings. Reliable revenue sources for transitional care, which is needed when a patient moves from a care facility back to their community or from the community back to a care facility. There's VA benefits. Services at home and in the community are part of the VA medical benefits package. All enrolled veterans are eligible for these services. However, to get the service, you must have a clinical need for it, and the service must be available in your location. Services in the VA standard benefits package include geriatric evaluation to assess care needs and to create a care plan, adult day health care, respite care, skilled nursing home health or skilled home health care, VA standard medical benefits, veterans must be enrolled in a VA healthcare benefits before applying for VA long-term care services and receive care through a VA facility on a regular basis. Then there's the Older Americans Act. The Older Americans Act Title VI has no age requirement, and the tribe can determine eligibility. The Older Americans Act Title III eligibility is 60 and up. There is long-term care insurance, and that covers many costs of nursing home assisted living or in-home care that are not covered by Medicare, but the premiums are really expensive. They average around $2,700 a year, and that cost is far too expensive for many people. You have private health insurance, usually covers long-term care that is medically necessary for up to 100 days. State and federal grants, and these are really popular, especially amongst tribal organizations and clinics, and they're good for creating a new project or starting a new program, and only provide money for a limited amount of time. Grants also require the use of funds be limited to a specific set of activities. Then there's the Indian Health Service, or IHS. Because of the Indian Healthcare Improvement Act reauthorization made permanent in 2010, tribes can now include LTSS in their self-governance agreements with IHS. LTSS is now an allowable expense for IHS funding, but there are no funds mandated to add LTSS allowable IHS services, so LTSS resources have to come from already existing contractor compacting funds. Tribal facilities can use existing IHS funds to cover positions such as CHRs or visiting nurses and services not reimbursable from other funders. LTSS services not covered by a state's waiver program, Medicaid or Medicare, can be supported with IHS funds. Overhead and indirect costs are included in the tribe's contractor compacting with IHS, unlike other revenue sources that only finance direct care. Then you have tribal support, and this allows for fewer restrictions on what LTSS funds and can be used for allowing tribes to have more control over their own LTSS programs. But not all tribes can afford this, especially the smaller tribes. And you have tribal cost sharing or resource sharing, and this is really important. Tribes already, between the health center, social services, senior center, behavioral health, already provide a lot of LTSS services. By doing tribal cost sharing, you can expand those tribal dollars even more and provide more services. But this requires tribes to be innovative and creative in identifying existing tribal resources. And this will require extensive coordination and a commitment to breaking down those programmatic silos, which is also critical. Tribal departments can interact with each other, and it will help stretch dollars further and provide more services. You can split staff salaries across different programs. For an example, the clinic receives IHS monies, aging receives money from the Older Americans Act, social services receives money from the BIA. Medical supplies can be purchased through federal contracts utilized by the clinics. You can go in together with different tribal departments and buy in bulk, like through the aging programs, schools, social services, etc. You can leverage facilities such as sharing kitchens and utilizing empty space in other facilities. Accurate and detailed documentation and coding. This increases third-party revenue and reduces denials or delays due to requests for more information. Examples of this is detailed documentation, and you need to make sure that the providers are educated on the importance of detailed documentation. And through the age of the EHR now, it's a little bit easier to do since the providers have their own templates that they can just click on for each service that they provide, medications dispensed, medical supplies, equipment, etc. Include V codes, personal and family histories, and comorbidities. This lends to necessity, which will help with reimbursement from the insurance companies. Trying not to use non-specified codes. This happens a lot, not only in tribal facilities, but at hospitals and outside medical providers. Make sure to follow up on unpaid claims in a timely manner. Make sure the patient's insurance is updated regularly. If billers have questions about information or lack of information, they need to make sure they communicate with the providers. And this often does not happen. When I was a health director, these are just some of the issues that I encountered when I first came to work for each of the facilities. As they were corrected, the revenue went up drastically. And the more revenue you get, the more money that you can put back into services, hiring more providers, community outreach, and the like. If a claim is delayed due to a request for information from the patient, then follow up with the patient to ensure the information is received in a timely manner. Make sure the clinic is a preferred provider for all insurance companies used by the patients. Oftentimes, a reduced payment agreement can be negotiated while going through the process of becoming a PPO. A lot of times they will agree anywhere between 40 and 80% reimbursement while you're going through that process. It can happen quickly, take only a few weeks, or it can take up to a few months. On that note, I would like to thank you for the time, and I will turn this back to Becky.
Okay. We have gone at a breakneck pace, but we'd like to bring Larry Curley back. And Larry, I wanted to mention that there's some questions in the question and answer. Would you like to look at those, or? I can read them to you if you'd like.
Yeah, I would like that.
Sure. Okay, the first one is, are there case studies from tribal communities that have integrated their elder services with veteran services, clinic, Head Start, etc.? My tribe is extremely wary of sharing information about elders, even with other internal departments / services, and this could be a stumbling block for our elder services department to do even a needs assessment.
That is so true. In my experience working with tribes, there's always a group of people, programs that say, this is my program, I'm not going to share it with you, that type of thing. And so, yes, that is a major stumbling block in a lot of tribes. Become very territorial. I understand that. But I think one of the things is that if one really believes that developing that kind of a coordinated collaborative system, persistence, just need to keep trying, keep going at it. It might very well be that some of these program directors have been there too long. I don't mean to sound crass, but maybe some of those people need to be replaced at some point in time because they have been operating in a particular manner for a long, long time. And I think they've become very possessive about their programs, and sharing information becomes a very arduous activity for them. But are there examples? Yes. For example, Zuni Pueblo in New Mexico, a fantastic program. And so if you're interested, go to our website. There's a video about what they do. There's also Cherokee in Oklahoma. Cherokee Nation has a dynamite program that you might want to check out, where they have integrated a lot of these kinds of services. And another great example is Oneida in Wisconsin. And check those out. Those are really great programs. Becky?
All right. And I believe Brittany is responding that a question about the slides being shared. I believe the slides will be shared afterwards on the LTSS Technical Assistance website. And now the next question is, are there any tribal providers in the Los Angeles and San Diego counties who are on this meeting that can share their contact info? Thank you. So that sounds like it's just a call to anyone on the call who's in that area to reach out so that people could connect. I saw there were around 58 or so participants. So if anyone wants to respond in the chat or the Q&A, that would be great. How are tribal agencies / providers seeking to work partner with health plans in preparation for Cal AIM in California. What does that look like?
I'm not familiar with the AIM program there in California. I do know that we have a tribal representative from the California area who is our board member from California. And Becky, you might want to share that information, who our board member is, that they might be able to contact and begin to navigate the system there in California. But I must say about California, they have one of the most liberal Medicaid program in the country, just like Washington has a great program as well, such as well as Wisconsin. So, Becky?
Yes, sir. I will try and get that information into the chat box for you. His name is Stan Rodriguez, and he is our Pacific Region representative. And if I don't find that properly and quickly, it is on our website under About Us, under board information. We have his contact information there. The next question is, who in the tribal agencies can health plans reach out to? Thank you.
I'm sorry, could you read that question?
Who in the tribal agencies can health plans reach out to? Thank you.
I think that if we're talking about the elderly population, now the beginning point should be the senior center or the elderly program director in that particular community. If there is an advisory council to the senior program, there usually is a advisory council. And those are composed of elderly who say, this is what we need, this is what we want. And the program director usually tries to implement the programs that are most needed. So they might want to sit down and start talking with the project advisory council, the elderly project advisory council, and the senior program director in their communities. That's the beginning point. And I think, as everybody knows, everything at the tribal level becomes political. It would be good to find someone in the tribal council who is supportive of what you're trying to do and recruit them to be your champion within the political structure of the tribe.
Okay. Well, I think we've addressed all the questions. Here's a message from Linda Soto. I just want to thank Larry for his life's work here too. I have an MPH and I am in my AIT year in Southern Arizona, taking my LHNA exams in March 2022, and I'm a tribal citizen. It's an honor to participate in the webinar.
Thank you very much. Thank you very much. I appreciate that. I wish one thing about aging is that the aging population, the elderly population, is growing in the United States, and especially in Indian country. We need more young people to get into the field. I started in the field when I was 24 years old, and here I am over a century later, it feels like sometimes, still in the field. And I've seen a lot of good programs, but I'd like to see them even better.
I just would like to add too, we've been mentoring some people at NICOA as well, trying to bring in that new generation of people in the field. There's a message here that says, Yolanda Denario, I'm located in California, my information, and she provides that. She's Hopi, San Felipe, Pueblo, Blue Shield of California Long-Term Services and Support Senior Provider Relations Representative, and then an email. So that person who had that question earlier can connect with her. I guess, oh, it looks like maybe there's one more thing. I wanted to share this article with you all. I believe it is the solution of healthcare on Indian reservations from Randall Benally. I don't see a link though. So if you were able to provide that to us, we can share that with everybody. But do you want to, and then here we have Cheryl Davis, I'm sorry, Larry, licensed healthcare producer in New Mexico. I work with Medicare beneficiaries. So a bit of a networking opportunity for people if they'd like to connect with each other. That sounds good. Would you like to wrap up? We're almost.
Yes.
Yeah.
I wanted to just mention one of the things about the long-term care facilities portion is to just let the people know that the reason why that's a part of it is in terms of the continuum of care. There are people who are going to require institutionalization. And I just want to note that in Indian country today, there are only 16 nursing homes in Indian country with 851 beds. Studies have shown that in any given time, 5% of the elderly population are going to be in nursing homes in this country. If you apply that 5% to Indian country and Indian elders, we're talking about 13,612 older people who are currently in nursing homes somewhere in the United States. So there is a drastic need out there in that sense. But again, the idea behind the LTSS is that we need to keep our elders at home for as long as possible and prevent institutionalization. But in just responding to the needs out there, I think finally, just overall, my thought about where we are as Indian tribes, as Indian organizations in the field of aging, is that to me, our elders are the key to the preservation and continuation of Indian tribes. So all of the stuff that we just talked about, the question sometimes you ask is, so what? Well, to me, our elders represent the history, the knowledge, the custom, the traditions, ceremonies that make us Indian people. It's what defines us as Indian people. The language, so important. And in a lot of ways, I see the elders being that key, not only to the past, but the continuation of Indian tribes into the future. You know, I'm a member of the Navajo Nation. And one of the things I used to say was, wouldn't it be great if there was a possibility that I could be frozen, put into a time capsule, and 2,000 years from now, have that time capsule open up. I get unfrozen, and the door opens up, and there's this red-headed, blue-eyed woman standing there. And she says to me, that would be the most fantastic thing in the world, to realize and know that the Navajo people have survived for 2,000 years. That to me is what our elders represent. They are the key to the future. They are the key to the continuation and continuity of Indian tribes and Indian people in this country. So with that, Rebecca, thank you for the opportunity. And for all of you who are out there, thank you for the opportunity to share our view and our knowledge and what we're trying to do in the field of aging. Thank you very much.
Thank you, Larry. Thank you, Cindy. Thank you, Mike. Thank you for the opportunity for us to take part.
Thank you. Well, on behalf of CMS, we would like to thank our panelists today. If there are any additional questions, please send them over now. If not, have a great rest of your day.